Good morning. It's great to be here. So much important work going on, but let me start by really explaining why I'm here. So 39 years ago, after graduating from college with a major in mountaineering and a minor in East Asian Studies, I was completely clueless about what I wanted to do when I grew up. So I decided to drive an ambulance in Somerville, Massachusetts, about 3 miles from where I grew up as a faculty brat at Harvard, of a Harvard professor. So the kids, the people I was taking care of in Somerville were getting absolutely terrible care. Kids were dying of things that my classmates never got. And I thought, you know, gosh, maybe I enjoyed this kind of clinical stuff, you know, trying to save people's life on the ambulance, although I probably never did. And there was a real opportunity to improve the quality of care in the United States. It was, you know, the technical term would have been pathetic back in 1975. 39 years later, I've got to say I feel incredibly lucky to have been involved in health policy and trying to put these ideas of accountable care organizations into the policy environment, but I'm still deeply frustrated by how lousy care is. My daughter has a serious and persistent mental illness, complex bipolar. She gets absolutely awful care every time she's hospitalized. They don't know her prior problems. Her providers don't come see her when she's in the hospital, even though they're they're less than 100 yards away. So we really have to fix this. I don't have another 39 years. There's some people young enough here who I suspect have 39 more years to devote to this work. But it's time for us to get going. And I think we're on the cusp. And that's really what I want to talk about now, and try to share with you some of the current moment in health policy, and then how we've thought about using measurement to accelerate change in delivery systems, and then focus it in more directly on shared decision-making, informed choice, and how we might take advantage of all of the progress that's going on in this room to get serious about how we hold these organizations and providers accountable under the new payment models we're going to see. So the problems confronting the US healthcare system are pretty well recognized. We know technical quality still is remarkably uneven. There are unsafe, unreliable systems everywhere. Nowhere near even 50% of surgeons are following the surgical checklist. So care is unsafe. Costs are completely unsustainable. We're bankrupting our kids, whether it's through the federal government or our schools, which are now spending more and more on healthcare for their teachers and having to increase class sizes and cut back on teachers' aides because of the rising cost of healthcare. And then I love Al Mully's term for the problem that shared decision-making, the failure to implement shared decision-making has, this silent epidemic of misdiagnosis. If we think wrong side surgery is a problem, Al's term, wrong patient surgery is truly a problem. The underlying causes are really increasingly well recognized. We've heard this morning about, this one-way, patriarchal, physician-dominated way that we believe that patients need to get care, that docs can tell them what to do. That face-to-face one-way model can't be sustained. It's the wrong model. And we have a flawed payment system that reinforces the fragmentation, that reinforces the lack of coordination, and that drives the overuse that we're seeing. What's really remarkable, in the United States at least, is the recognition that we have to change dramatically. It was the recognition that we are wasting 30% of US spending on unnecessary avoidable stuff. That's pretty well accepted. If you look at the Institute of Medicine, 3 other consensus reports, everyone says we're wasting about 30% of US healthcare spending. And you spend much time in other healthcare systems and you see that they're wasting tremendous amounts of resources too, so you can't say this is just a US problem. And so there's strong consensus here that we need to move away from fee-for-service payment, and that we need to move to the kind of payment models that Gene was emphasizing, this notion of value-based payment. that we will start paying based on the kinds of care that, how good the care is you're delivering and how effectively you are able to reduce costs, improving the value of care for patients. Well, what does this really mean in terms of the payment models that we're seeing out in the real world right now? There are three major flavors of payment reform in the United States that I think are here to stay. One is thinking about reforming primary care through new ways of paying for primary care services, the patient-centered medical home. Most of you have probably heard about that. In most U.S. models, it's a pretty simple notion. That is, we'll give docs, $3 a month per patient or $10 a month per patient more in their, under a fee-for-service model in their primary care practices in order to support the activities that are not reimbursed under fee-for-service practice under current fee-for-service practice in primary care medicine. The model is promising in that we know that primary care needs support, but almost none of the implementation of the patient-centered medical home includes any measures or requirements that they actually improve care. It's sort of, trust me, give us some money and we'll do a better job. So there's a tremendous need for measurement about how we improve primary care within the United States. The second general payment reform model that's being advanced pretty broadly is this notion of bundled payments or episode payments. So you will pay a single dollar amount for a knee replacement or maybe for an episode of diabetes care. There's lots of support for this. All of the people who deliver services like episode payments because they'll do quite well under episode payments, right? They get to keep the savings. If you have the fixed price and you achieve savings, you reduce costs, providers will be able to do quite well under episode-based payment models. There are some hitches with the episode-based payment model that we have to at least be cognizant of. The first is they're never linked to any quality measures. So one of the ways you achieve savings is by stinting on care. So there's great concern about that. The second issue with episode payments is that the boundaries are kind of contentious. It's easy to think about in a total knee replacement. Well, we used to do post-op follow-up on day, we do several follow-up visits, and on day 90 or day 89, we would have a follow-up visit and some follow-up tests. Well, if they've decided to develop the bundled payment that includes those follow-up visits, we'll just delay those follow-up visits till after the interval for the bundled payment, and then we'll get paid twice for them. Once for the service we didn't provide now that it's a bundled payment, and again under fee-for-service for the service that's delivered after the end of the bundle. So their insurance companies have figured out that this is a really challenging model to implement. And of course, bundled payments don't take away the financial incentive for overuse, for doing too much. They have to be successful. They have to be linked to measures of informed patient choice. They won't work. They will lead to overuse if they're not linked to the work that we're doing here. The last payment model that seems to have gained some traction is this notion of accountable care organizations. Developed initially, in response to the managed care backlash of 1990s, Jack Wenberg and others of us here started to think about, would there be ways of developing virtual capitation? So we identified the population of Randolph, Vermont, just 30 miles, got to get my directions right, west of here. Randolph, Vermont, a relatively small population, a single hospital, but we knew all the patients from the insurance claims records. We knew everyone who lived there. We could calculate what it cost to take care of them for a year. We could predict what next year's costs would be for that population, and the model that we proposed to Medicare and to the Robert Wood Johnson Foundation and others was, if we reduce costs for that population, we, the providers, should get a share of the savings. That model was generalized once we recognized that most docs practice in natural referral networks around one or more hospitals. There are natural care networks in almost every healthcare system now. We've seen that this is true in Ontario as well, through the work of Therese Stuckel and others. So that the notion that if you can define the population served by a group of providers, you can then figure out a virtual budget for that population And we made a few additions in the development of the model as it was worked through here, and that's to say, let's figure out what your costs are in the future. We'll give you a share of the savings, but we'll make giving you that share of savings contingent upon improved performance. We'll have to have measured performance, and then you'll get a share of the savings if you document that you've improved care. Well, that's given us the hook, now that it's in the legislation, to start think about what we should measure. And so ACOs were, for reasons of remarkable good luck, happenstance, if you have economists working with you who can make things look like they're saving money for Congress, Congress will decide to put your program into any legislation because that gives them money to spend on pork barrel projects somewhere else. So ACOs were probably included in the reform legislation primarily because we got scored well, not because they thought it was a particularly good idea, but because it gave Congress some more money to play with. So what's happening right now? And I think there are three, this is a particularly important moment in the progress of healthcare reform for three reasons. First, change is coming. You know, whether you look at whatever the Supreme Court says, bipartisan support on both sides of the aisle for moving to value-based payment. Michael Levitt, likely to be the in charge of transition for the Romney campaign, has been very clear that accountable care is coming, and value-based payment will be here. I think second, we are on the cusp, thanks to a lot of progress in electronic health records, a lot of progress in the development of web, tablet-based, smartphone-based technology, to being able to implement patient-reported measures in routine clinical practice. There are a lot of models already out there that have shown us how to do that, whether it's Dartmouth-Hitchcock, whether it's the Karolinska Institute and elsewhere in Sweden, whether it's Kaiser, there are group health. They've all shown that it's now possible to start to implement measures at the point of care routinely and feed the information back to clinicians and roll them up to be used as accountability measures. So it's going to be a lot easier with these tools to measure what we need to measure. And then I think the pressure to get the measures implemented is clear. Reform won't work, ACOs won't work, bundled payments won't work. They will all lead to harm if we don't get the measurement right. So there is, on all sides of the aisle, in Washington, in Congress, there is a lot of interest in trying to figure out what to measure and how to do so. So, given this opportunity, what do I hope might come out of this conference? I understand the group work is going to focus on, this question, what is the most important priority or key issue around measurement that will help accelerate the broad adoption of shared decision-making in clinical practice? We've identified a lot of possible things we can talk about. But Karen, I think, set us up very nicely to say, so, what do we do? What are the barriers? What are the priorities that we need to address? And some really thoughtful work here could have a profound influence on how we do our work at Dartmouth, what happens with the High Value Health Collaborative, which now has a $22 million grant to invest in implementing shared decision-making, but no clarity yet on what the measures should be. So, with implementation starting in 6 months. So we have to get kind of real and serious about what we want to measure and implement. So there's some folks from Canada here. I have 3 daughters who play hockey, and the great one taught us, to think about that it's really important to skate where the puck is going to be. A group of us, starting about 3 years ago, reframed that question to say, what we really need to do is think about how we're going to help people skate to where the puck should be. So it's a slight reframing of Gretzky's great quote. But that was, it started to be our way of thinking. If we want to be someplace in 3 to 5 years, what do we need to do now to get there? And there's sort of 3 questions that emerged from this thinking. The first is, what's possible right now? Because 6 months, we got to get going. But we really have to think carefully about where we want to be in 5 years. And if that's where we want to be, then you have this really hard work of, oh shoot, what do I have to do now to make the stuff in 5 years more likely? How do we do that shared work? And that's really hard social organization, getting some agreement about what the pieces of that puzzle look like. What might we be able to accomplish in 5 years? Who could do what? So when we were doing this thinking, we reached out to the National Quality Forum, Janet Corrigan at the National Quality Forum, a number of others who had been thinking about measurement and accountability, and started to try to put our thinking together around, if we need to move to measures of value, what would the pathway look like? And this is the picture we came up with. Starting on the right, we knew that we had to understand the pathways for adoption of measures. Who can help us adopt measures? The National Quality Forum. What is required to lead to endorsement of a National Quality Forum endorsed measure? There are only, 700 of them now, I think? But you have to show importance, feasibility, usability, the kinds of things that Karen was presenting to us a few minutes ago. But CMS can make decisions about what to implement. They can choose to adopt non-National Quality Forum endorsed measures if they so choose. And then the meaningful use criteria, which is the United States federal government's decision to provide substantial financial incentives to clinicians, up to $40,000 per physician who adopts and meaningfully uses an electronic health record. That's a lot of money on the table. And what the federal government put in as an additional stipulation was there have to be measures that show that you are meaningfully using those electronic health records. There's phase 1, phase 2 is just about, the measures for phase 2 are just about to be released. We're kind of hopeful that thanks to some of the work of the Gretzky group, there will be included some patient-reported outcome measures in that as required elements for electronic health records. In the stage 2, there will almost certainly be a number of patient-reported outcome measures included in stage 3. Probably 2 years from now, which means we have a window of opportunity to try to get going to demonstrate some useful measures that can be embedded into electronic health records that could then be required for all electronic health records as a component of the wiring, if you will, of every electronic health record in the United States. So there are we thought those were the 3 most important federal pathways for accelerating adoption of these measures. If you're going to get measures adopted, you actually need measure stewards who are going to pay attention to managing these measures and updating them and keeping them live and ready for use by the regulators. And so we identified some potential measure stewards in various versions of this. We have had, proposed informed choice measures as another category under the measured stewards. Certainly I'll show you some CAHPS measures in a second. There's a little heads up about where the discussion will be tomorrow. But if you're going to adopt measures, getting to the bottom there, routinely in clinical practice you need platforms that do it. You need tools that are going to make it easy for patients to do it. Tools that are going to make it useful to clinicians to have those measures. So patient interfaces, provider interfaces, and then standards that allow everything to talk to each other. The left-hand side of that figure really was a recognition that, to get to better measures, we have to continually implement them and test them and advance them. And so we needed a number of test beds to join us in thinking about how we're going to do this measurement. You see the beacon communities listed there. That was a big investment by the federal government in putting measures and tools in place to accelerate the adoption of electronic health information, EHRs, HIT, health information exchanges, and others. So the beacon communities looked like a promising place, and we worked with some of them. The High Value Health Collaborative, I think that's what HVHC stands for, and perhaps accountable care organizations could serve as test beds, and we identified a number of who would like to work. And then the test bed coordination center and the leadership team is, gosh, how do we pull ourselves together? We knew that we needed some national coordination. That was Janet Corrigan at NQF. We had informal groups that have worked with it. We've now done some work to try to think about a more formal structure for that that would support implementing patient-reported measures, including of decision quality nationally, and have the test bed coordination center that would make it possible. So that's how we thought about the Gretzky model. It's clear, this is just a cartoon of what Jean showed earlier. If you look at the way these tools are being implemented, it is quite feasible now to implement using a variety of tools, web or mobile apps, kiosks in practice, patient-reported measures engines integrated with EHRs to get really good information, good risk prediction, as John Spurtis mentioned, integrated and available to patients at the point of care and useful to clinicians. So that is possible. Let me spend a second on why I think this, why we have a pretty remarkable window of opportunity here. Because accountable care organizations are already required to meet a number of quality measures, and those will be updated yearly. CMS, the Centers for Medicare and Medicaid Services, are working hard to come up with a set of standardized, to align all of their measurement initiatives across all of the programs that are underway, and implementing measures of shared decision-making and informed choice, of effective shared decision-making and informed choice, is at the very top of the list of things that people want to achieve. And there's a place for them to go, be put in systems that are starting to adopt these new payment models. This is the list. I'm glad the font is so small that none of you can read it. But it is the full list of accountable care, of measures, the 33 measures that are required for ACOs. Now, there are 60 federal ACOs now. There are 200 odd private sector ACOs. We're expecting another 100 to be announced by CMS in the next few weeks, and many, many more at the next round of release. So there are lots of places that are starting to look at these measures. The CAHPS measures, I'll spend a little bit of time, just a little bit more detail on these measures, because I think, as I look at the threats to quality that are imposed by global payment, let's stint on care so we can make more money, these are actually pretty good given the kinds of incentives that would be placed on docs to not do what they should do. Can you get in to can you get timely care? Gene mentioned in his introduction the importance of access, and patients care a lot about getting access when they need it. If patients got an appointment for urgent care as soon as needed, an appointment for non-urgent care as soon as needed, after hours care, seeing their provider within 15 minutes, those are pretty high expectations. How many of us ever had any of those experiences in our most recent encounter? How many of us could answer yes to any of those questions? I know I couldn't with my provider here at Dartmouth-Hitchcock. How well does your doctor communicate? These are probably not great measures of decision quality, but they're not bad. There's something there, and I think it's useful for you to see as we the task that I'll ask you to work on is say, so what could we do now to measure, to help ACOs do even better, or bundled payment programs such as the High Value Health Collaborative do better. Understanding what's currently being measured may be helpful to you. Access to specialists, people care about access, and health promotion and education. And at the bottom there, you see the CAHPS measures of shared decision-making that I'm sure Susan will talk more about tomorrow. In the last 12 months, did your provider talk about starting or stopping a medication? When you talked about it, how much did this provider talk about the reasons you might want to take a medicine? And so on. So there's something there now being measured for for major health plans and for accountable care organizations as they move forward.